Welcome to the meeting number 3 of the House Budget Review Subcommittee on Health and Family Services. The meeting materials were put online earlier this week and made available for downloading. At this time, we'll have the Secretary call the roll.
Representative Bowling.
Here.
Representative Fleming. Representative Raymond.
Here.
Representative Wilner.
Here.
Representative Petrie. Representative Reed. Representative Heverin. Representative Moser. Chair Bentley.
Here. Okay, next, do we have a quorum for the minutes? We don't?
Yes.
We do have a quorum.
Next, we have approval of minutes from the February 15th meeting. Do I hear a motion?
Second.
We have a motion and a second. All approval say aye.
Aye.
Aye. Opposed, like sign. The minutes are approved. First up this morning, we have Commissioner Stack and Mr. Tuggle to discuss the proposed replacement of our state lab. This is very important to me. I'll give you a little background. I taught 31 years for Ohio University, and I taught microbiology and psychopharmacology. And I know the importance of this lab. So I know down here that wheels turn slowly. So today's the first mile. But we're going to need a lab to keep up with the future. And so, Dr. Stack, you and Mr. Tuggle, would you please identify yourselves for the record? And members, hold your questions until after the presentation, please.
Well, good morning, and thank you, Mr. Chair, for the opportunity to be here. My apologies for my froggy voice, though I feel fine. I'm not fully over the laryngitis I had last week. So this is a really important topic, as you identified, and I'm very, very grateful for the opportunity to begin this discussion today. So I'm going to go through a very short slide deck and highlight that with some additional comments, and then look forward to any questions you may have. So this is a photograph I took a week ago of our State Central Laboratory building. For any of you who know where Sage is, it's right across the street from Sage, right off the exchange. It's a 30-plus-year-old building. It has multiple state government tenants. It only has state government tenants, to my knowledge. They have the Kentucky Department for Public Health, both our Division of Laboratory Services, which is our much larger lab, and also our Radiation Health Lab. The Kentucky State Police have an office there, as does the Kentucky Medical Examiner and the Kentucky Environmental Cabinet. They all operate laboratories, but these laboratories are not all the same. The complexity and the variety of things done differ substantially. These are some examples of KRS statutes that specify requirements that the Commonwealth must provide for through the Cabinet for Health and Family Services, through its Department for Public Health Laboratory Division. Some of these things are really central to our operations. The biggest and most obvious, and I'll go into some numbers for these services on the next slide. We do all newborn screening for every newborn child in the Commonwealth of Kentucky. There is no in-state alternative to that. If we were unable to do this, we would have to send those specimens out of state to another lab at substantial elevated cost and degraded turnaround time. We also provide we are the only biosafety level 3 laboratory in the Commonwealth of Kentucky. To my knowledge, there are only about 200 of these in the entire United States. The only level higher is a BSL 4, and I think there are only 2 of those, one in New York and one at the CDC in Atlanta. That's where Ebola patients would go or be tested. Otherwise, these 200 BSL 3 labs are the ones that would do white powder investigations. If you're worried about anthrax or ricin or some of those other toxins, I think we can all appreciate the enhanced measures that have to be taken to ensure that the people running those tests and the people near them are not exposed to those contaminants. We also do lead testing. We do milk safety testing, for milk throughout the Commonwealth. We also, that's not on here, but we are a lab that can enable other hospital labs and other medical labs to be certified for new tests. So we have the ability to, when an outside lab brings on certain kinds of tests, to be the one that verifies or validates the accuracy of their results so that they can go into production for other tests. So we provide a wide array of important services, including genetic sequencing, polymerase chain amplification tests for various conditions, really sophisticated culturing and other types of testing for pathogens that are rare, uncommon, and for which hospitals and other medical labs would not be able to provide. They'd never have enough volume to justify bringing that capacity in-house. So you have to have a centralized state lab to provide those services. So it is quite literally an irreplaceable service. I'll comment, I do have discussions on a regular basis with the other state health officials. Every state in the United States and the 9 territories have a designated state health official, and of course I'm the one for Kentucky. There are other states in our southern regions who over the last 3 years have had instances where their laboratory, because of data technology or insufficient capacity, had to reach out to their border states to provide testing services for the residents of their own state. And of course, we work very collaboratively. We're all here in the public health world and in the public health laboratory world to help and support each other as needed. But it really did leave them in a difficult position, having to go out to other labs who themselves were already stretched, seeking opportunity to get the testing they needed for their own residents. Here's drilling down just a little bit more for our actual Division of Laboratory Services. There are, in 2022, there were 52,308 newborn screening samples performed, but we test for we test for 55 inborn errors of metabolism. These are both rare, but they are also catastrophic if not found early. These are the kind of things where if you don't change a newborn's diet or take other interventions, they can have irreversible harm caused quickly. That's why it's required that this be performed on all newborns. Again, it is such a low volume frequency of positive tests relative to the total number that individual birthing centers and hospitals couldn't bring this in home, because in order to validate each one of those 55 tests would be just too much burden of work for such a low positivity rate. So it has to be centralized. So this means that for these 53,308 newborns, we provided nearly 3 million total tests to support that screening program. Additionally, this is the biosafety level 3 laboratory work I'm talking about. That's called the Federal Select Agent Testing Program, and there's a network of these labs, and we are one of them. In 2022, we tested 4,024 samples for a total of 55,755 different tests. So if you have a white powder that pops out of an envelope at some government official, you have to test for a variety of things: anthrax, ricin, perhaps some other bioterrorism agents. That's why you have 4,000 samples but 55,000 tests, because you have to test for multiple different contaminants. Those testing facilities require things like specialized hoods to keep everything secure and isolated from the people doing the test, often airlock type procedures where you go through an entry room and then into a testing room and then back out through the entry room and out to the external environment so the contaminants are not spread. They are very highly regulated, very specialized, and there is no alternative within the Commonwealth for those services. And then our microbiology services include advanced testing for bacteria, viruses, that include various specialized culture techniques and also genomic sequencing. And you remember during the COVID pandemic was a very prominent example. There was no existent test for that disease. The CDC in the United States is the one that creates the first pilot test in the country. And then the first next layer that those tests get shared with are these public health labs. So there was a period in time where the state's public health lab was the only lab in Kentucky that could provide that testing. And then when we went out and found other partners, we had to sometimes be the lab that validated that those other partners' results were accurate and correct. And so again, we helped to bring on other bandwidth by supporting other labs in the state. And then we are central to numerous other quality, compliance, and safety programs, including supporting certain OSHA activities and various other initiatives that are important to the state. So again, here's the picture of the building. When I came in as commissioner, I think we all know I got a journey that none of us expected. We all shared that journey. When I started on February 10th, it was just a month later we had our first COVID patient, and my life as a commissioner unfolded very differently than any of my predecessors. Along the way, while being distracted by COVID, obviously, it became apparent that our laboratory building had aged very much to the near end of life use or life expectancy, and there were substantial problems. Now, I went through the lab with our laboratory director and operations manager at the time, and identified numerous different areas where there were problems. Eye wash devices that, because they're so old, bring rust with the water. And obviously, we don't want people to wash their eyes with rusty water. Decontaminating showers, where, whatever reason, when they built these, there's 47 or so of them in this building, they didn't put any drains underneath them. So if you use them, they flood the people beneath you. And when I asked the rationale for that, the best they could come up with, our people, no one in the lab now was there at the time this was built, was that you weren't allowed to discharge contaminated water into the regular sewer system, but instead we could discharge it onto the head of the person and the floor beneath. There are a number of these just inconsistencies that make no sense, including that those showers are outside the laboratory, and you would never want to do that, to have the contaminated person leave the secure lab and go into a hallway. You'd want to have the shower in the laboratory to contain the contaminant. So these and a number of other things, such as autoclaves that are at the end of their life expectancy, they've been there 30 years, refrigeration units that really are antiques by today's standards, a number of other things are serious problems. It is, as Representative Bentley commented, the wheels of state government often move slowly. In order to address something like this, we have to have a 6-year capital plan for our agency, the Department for Public Health. We have to then have all of our agencies roll up to a cabinet and get into the cabinet's capital spending plan. And then the governor has to look at the totality of all the needs for the executive branch. And then you have to get into the governor's spending plan, which is embodied in his biennial budget proposal. We did all of that in 2022. It was tough, though, because when I became aware of the problems and finally learned enough about the process to start engaging, it was the summer of 2021. In order to start a project like this, you have to get a feasibility study from a third party. So you have to go through the finance cabinet. Of course, they have procurement requirements to get these vendors. So we did that, and we did in a really expedited manner from about August until December. In just that 4-month period, we got a fully done feasibility study, and we were ready with that, but it was just too late in the cycle. It hadn't been in the normal cadence. And when the budget in 2022 got released so early by the House, I think it just didn't have a chance to have, the hearing that it otherwise would have had things unfolded in a more normal way, where we had this in the process earlier in 2021, where the House Budget Committee had access to that information earlier in the process. But it did make it into the governor's proposal. And so you will see this spring, this is in the Department for Public Health's capital proposal. It will be in the cabinet's proposal, and it will be in the governor's budget for the 2022 biennium. And so the final stop on this train is the legislature hopefully taking action on this. And again, I'll share some additional reasons why it's so important. So this is clipped, that little central laboratory building, that's clipped from the feasibility study. It's 200 or 300 pages long. Anyone wants to read it, we can give it to you. It'll cure your insomnia. But they had key findings, and so I just quoted this from the top. This building was from the 1990s. The building codes are now 30 plus years old. They have a whole section that documents many of the deficiencies, but 2 really big ones stood out. One is there's not enough space to safely and effectively conduct the work. We've grown in the capacity. You can imagine the laboratory equipment that they had in 1990, about the time this was built, and the laboratory equipment we have now is not quite like the Stone Ages to Star Trek, but it's kind of along that continuum. Our machines can do stuff we could never have imagined at the time the current building was built. And that's created real problems that lead to the secondary issue here, which is a lack of proper stability of environmental conditions. The HVAC systems that heat, cool, and manage the humidity in the building are not up to the task. So when you go in our newborn screening lab, providing those nearly 3 million tests a year with really quick turnaround time for the birthing centers in the state, there are stainless steel vents from the machines up through the ceiling of the building, up out into the roof to try to vent heat out because the building's HVAC system cannot maintain proper temperature in there. In a different room, because they've tried to calibrate things to provide for environmental conditions, when you open the door, it's almost like you open a wind chamber, and then any loose papers on the desk in the lab get blown around. I think we've got that a little bit better now, but that's a recurring problem. We have a lab that is called the gravimetric room. Mettler balances, for those of you who remember your chemistry classes in high school and college, It has to have very, very precise conditions to do that delicate work. There are dehumidifiers, fans, and other devices in that room to attempt to keep it at the right temperature. But when we get to the heat of the summer, we can't maintain the right conditions, so that lab goes offline within our bigger lab. That endangers our accreditation by national accrediting bodies, because you can't be offline if you're the only state or the only lab doing these things in your state and still maintain your accreditation. So there are significant problems that cannot be fixed for the really high precision needs of the current modern day equipment in the building as it currently exists. One other thing of note, and when I show one of these later slides, there's maybe the next one. Yeah, so here's the plat for the land that we're built on, and it's small and hard to see, but the gray area on your top right there is the existing footprint of the current lab, and the circle in the front is the parking area. The proposed new laboratory would be that brighter white rectangle on the back. The reason this is helpful, in addition to just showing you where the new building would go, is that the current building does not have redundant HVAC systems, which you would never tolerate in a lab of this sort today. You should have backup systems so that if the primary goes down, secondaries can take over. So this just happened over the holidays, the holidays we just concluded, where we were down to only one operating chiller or cooler for that entire big building, and they had to bring in rental chillers, and thank goodness we were able to get them. This was literally over the Christmas or New Year's holiday, so trying to get on a state holiday and get all this stuff in on the holiday was tough. But thankfully we averted any downtime or any machines going out of tolerance, because if the machines go out of tolerance or the reagents get too hot, you either have to discard stuff and or recalibrate the machines and revalidate everything. So it's a big deal. By building a new structure behind the current structure, the new building will become the backup for the current building and vice versa. So they will have separate independent HVAC system for the new building that will have the capacities to support the main building in need of a backup. And should the primaries for the new building go offline, the old building will be able to support the new building because they'll interconnect the two HVAC systems. Now remember, I told you there are other tenants in the old building. Some of their needs are not as intensive or precise as ours. Ours are the highest overall intensity for the specific conditions we have to maintain. But they also have to have conditions maintained for their labs, so that redundancy will address a mission-critical failure potential for them as well. And also, one of the other tenants, at least we're aware, was in the process of beginning to look for outside space at another facility, so the space we would vacate would solve their problem as well, because they would be able to expand into remodeled location within their current footprint. So this would make the best use of existing state property and physical plant, while also addressing the needs of the public health lab and providing for more stability of services for all the tenants. The cost is $185 million. I do want to share, as I mentioned, I do communicate with my health officials from other states. Tennessee, to the south of us, just opened a new $200 million lab for their public health lab, to put a southern border state in context. And also the following states either have just recently opened or have approved in their budgeting process and are now either in planning or construction a brand new public health lab. South Carolina, New York, Colorado, the city of Dallas, large metro areas, really big ones often will have their own. Virginia, Missouri, South Dakota, Pennsylvania, Delaware, Rhode Island, Nevada, San Diego, Washington State, Montana, Minnesota, Houston, and I mentioned Tennessee. So I don't know what happened, but there's a boom-bust cycle of funding that happens a lot of times. And after major events like we had with COVID, people recognize deficiencies that need to be addressed, or it provides the impetus or the opportunity to address them. The fact that I'm sitting before you today seeking your assistance to get this into the next biennial budget so we can move forward, I think the fact that all these other states and entities are doing the same thing hopefully adds some additional external validation about this is apparently the cycle and the time where people need to update this stuff, and we are not alone in this. And I don't think Kentucky wants to join the list of folks who had to send their specimens at elevated cost to out-of-state vendors at delayed turnaround time. Now the last slide is here. Now I'm going to observe, because our very attentive staff identified this, but The vendor apparently had arithmetic problems, not the public health department. It is not 55.5 months total, it's 55.4 if you add those numbers up. And I promised I would bring it up, right? 54.5, I apologize, I put the 4 in the wrong spot. But it is a long process. It's 6 years for the capital planning process, 2-year biennial budgets. The next opportunity is January of 2024 when the legislature does the next biennial budget. If it is approved, remember, if it's approved in a budget in April, the money won't start flowing till July when the next biennium starts. And then we start a clock, and that's all acknowledged that few things progress exactly on schedule in government work. You've got a 5-year horizon. So you're talking 6.5 years before we can occupy a new lab. And that building will now be closer to 40 years old, not over 30 years old. So folks, we are really at a critical junction. I asked the staff to also provide to you a one-pager. Last year, this was all moving so fast, as I acknowledged, but last year, the Budget Committee chair asked for a one-pager to summarize the reasons why the lab was necessary. So you should all have, I hope, a PDF that is a one-pager. Yep, I see Representative Bentley has it. That describes some of this narrative that I provided here in a little more detail about some of the problems that the lab faces. So folks, that's the pitch. I won't be your commissioner in all likelihood when this is built 6-7 years from now. Someone else will cut the ribbons. This is really for the Commonwealth. The Commonwealth needs to have this to support its citizens. And so I appeal to you to hopefully navigate this with your colleagues and hopefully to celebrate the passage of a budget next year that includes this as an important capital project. And Mr. Chair, I'm at your disposal for any questions.
No, I'm good.
I'm glad we started this today. And I'm a firm supporter of this program. When I was taking my dogs in the summer, air conditioning went off at the Major University where I was. They gave me 2 unknowns, and there were enough Bunsen burners that it was 120 degrees in the lab. So I identified my person really easy because I remember his pneumococcal white, so it's pretty easy. The other one I didn't know what it was. I got back to the dorm, I had a little diarrhea, and I guess with that heat, there was no way I could find I had a second unknown. So that's the dominant area. You cannot run a lab without air conditioning, humidity control, and we need this. And I will be a big advocate. We got to have this for our Commonwealth. Do we test dust?
If there's an indication for it. So like if you were concerned that the dust contained a bioterrorist, content, or if you were concerned that if there was a public health need, and you were worried about a specific type of contaminant or lead, like in dust in a home, and there were children in that home that had high lead levels, yes, we could do those sorts of things. And that would be a combination of probably a variety of labs in the building, but including that gravimetric room could be part of what's necessary.
One of my constituents wanted me to ask you that. Also, when I taught microbiology, I always taught my class to the micro lab at the hospital. And they always told us there were certain things they had to send to Frankfurt. Can you tell people here today certain things to send to Frankfurt, like the TB?
Yeah, so we do genetic sequencing for things like multi-drug resistant organisms. So there's things like TB, things like there's a yeast that's been a particular problem in nursing homes recently. So we do investigations for that. And the one thing I would comment on the dust or the multi-drug resistant organisms where we do those advanced tests, it's where there is a public health indication. So our state epidemiologies review those requests and they follow protocols, and then they use their professional judgment to approve. So you can't just send a specimen to the public health lab. You can't, if you want to just randomly test something because you're curious, you have to go find a commercial vendor. But if there is a public health indication for it, a risk to people in the state that the epidemiology team feels is substantiated, they are the ones who have the ability to authorize things. Now, there are a number of tests like the newborn screening or for advanced culture techniques and things that only we do, where the hospitals have a fast track. They don't have to go through an epidemiologist. There's a normalized pathway where they can just send those specimens and they just come to the lab and then we process them.
Two more questions. One, everybody want to know if you give us a visit to the lab.
I'd be happy to.
I mean, we might have to schedule it in the March.
Sure. Be happy to provide that. Just reach out to me and we'll do it.
Two, of course, this committee here is under the budget committee. So I'm talking to the chairman of the DNR.
Well, that one, Mr. Chair, I can comment on. So the part of the requirement for this third party is to provide a cost estimate. And so they provided a cost estimate before, and they have revised it and updated it. Now, hopefully, inflation's already lower than what they used, so hopefully that is an overestimate, because the lowest inflationary number they used was 8% for each of those later years, and it was double digits for the first year. So their estimate should be higher, hopefully, unless we have inflation that high going forward. So the $185 million should be a very reliable upper cap, and if we're fortunate, we'll come in under that.
Anyone else have a question? Representative Bowen.
Thank you, Chairman Bentley. Real quick, the $185 million, you said a third party. Who was the third party?
Omni Architects.
Omni Architects?
Correct.
Okay. That's all I needed. Thank you.
And again, if any members of the committee need or desire it, the feasibility study is all open record, and so we can provide that to you if you want it.
Great. Thank you.
You're welcome.
Okay, no more questions? Okay, thank you all very much for coming. Thank you that we started this process. And I probably won't be around.
Well, I'd love to come back and celebrate it with whoever's in this role. But thank you very much, Mr. Chair, and thank you, committee, for your service. I appreciate it.
Good morning. I'm Lisa Lee. I'm the Commissioner for the Kentucky Department for Medicaid Services. Thank you. Thank you. So first of all, I'd just like to give a little bit of an overview of the Medicaid program. We currently cover 1.7 million Kentuckians, over 600,000 children in the Medicaid and CHIP program, which is more than half of the children in this state. We have 649,000 Medicaid expansion members enrolled in the Department for Medicaid Services. And in fiscal year 2022, our administrative and benefits budget was a totaled $15.1 billion. So when we talk about coverage levels, when we talk about individuals that we cover in the Medicaid program, I think it's really important to put into context what that federal poverty level means, what it looks like. So I've highlighted in green here the federal poverty levels for individuals who are enrolled in Medicaid in the expansion level, and adults, which is at or below 138% of the federal poverty level. So you can see, for example, a family of four can earn $41,400 for the year and qualify for Medicaid, and that is prior to tax. So as we look at the average Kentucky expenses, I did put in here the Medicaid income limit for a family of 4. You can see that's $41,400. Again, pre-tax. Take out tax, housing, utilities, food and groceries for that family. And these numbers came from the Cost of Living in Kentucky 2023. I have the link in there if you want to go and look at it. And so you can see that the expenses for the average individual to live in Kentucky totals $43,220, which is more than the federal poverty level for someone to qualify for Medicaid. Expenses not included in the total here include clothing, transportation, auto insurance, telephone, for example, miscellaneous expenses related to school-aged children. And I wanted just to show this and depict this information to show what the families enrolled in Medicaid struggle with. They struggle with paying their bills, let alone dental, vision, and hearing services. So as of January 1st, 2023, Medicaid began covering services for individuals that we did not cover before. We currently will cover 1 pair of glasses or contact lenses per year for our adult population. We'll cover hearing aids, 2 dental cleanings per year instead of 1 for adults, root canals, crowns, and dentures. And there has been some misperceptions about what we're doing when we cover these services. For example, we are not covering full mouth implants. If an implant is medically necessary and that course of treatment is agreed upon by a member and a provider, it has to be medically necessary. And we believe that these new services is one answer to the workforce shortages in the state and the low participation rates of individuals in the workforce. We believe that giving them the ability to see, hear, and eat better and smile. We want to give individuals their smiles back. We believe that that's going to go a long way in giving them the tools they need to be successful in the workplace. And the reimbursement, we talk about reimbursement for the new adult benefits will mirror the child-specific fee schedule for dental. Currently, or prior to January the 1st of 2023, we had 2 separate fee schedules. We had a fee schedule for children that was higher than the fee schedule for adults. So the new adult benefits will mirror that child fee schedule, which means that the providers will receive increased reimbursement for providing those dental services to adults. For vision services, we will cover glasses or contacts for individuals over the age of 21. The ability to read medical instructions is very important for this population. Medicaid currently does not cover, or prior to January 1st, did not cover glasses or contacts for adults. It also lowers the risk of infection. People with glasses are less likely to be touching their eyes as often, so, and also safety reason. Less falls, they can see things in front of them. And I'll never forget my first pair of glasses. I was an adult when I got my first pair of glasses, and when I put them on, I couldn't believe the bright colors that I was seeing. I could see leaves on trees, and then part of me was so scared that I had been driving without those glasses and without that aid with my child in the car. So I was very thankful when I was able to afford glasses for myself. Our frames are limited to $50 per year per member. Our optometric Technical Advisory Committee is talking to us and making recommendations. They believe that that rate should actually be increased for better quality glasses as we go forward, so those conversations are happening. Lenses would be limited to 2 per member per year with price, and that's lenses for the glasses, price ranging from $28 to $56 each. Hearing services, again, untreated hearing loss is linked to higher rates of dementia, social isolation, depression, anxiety, and falls that result in injury among our older adults. And we also have looked at research that shows that hearing aids, within 3 years of getting hearing aids for those individuals who begin experiencing hearing loss, within 3 years of getting those hearing aids, the risk of developing dementia decreases by 18%. So again, providing these services now is going to offset costs in the Medicaid program in the future. Our dental services, we know that dental health is health care. We know that various studies have linked heart disease to poor dental care, even preterm deliveries, diabetes, things that we can prevent by covering at least one additional cleaning per year for our adults. We know that Kentucky Medicaid members go to the emergency room for dental services. For example, in 2019, we spent $9.2 million in dental services in the ER. Again, providing these services is going to offset some of those costs in the future. And we do know that NICU babies, for example, if we cover, we've looked at information, and NICU babies are very expensive. And if we can prevent those preterm births by delivering these dental services to pregnant women, that would be fantastic. And we cover over half of the births in this state. So again, very important to get those dental services for our adults. Many of you may know we have an EPSDT benefit. It's called Early Periodic Screening, Diagnostic, and Treatment benefit. That benefit covers 2 cleanings per year for children. It also covers all of the services that we're providing in our adult population. And I think it's a little bit unfair for us to, when somebody turns 21, to move them from from 2 cleanings to just 1, and then not help them take care of their teeth that we have been so diligent about taking care of as they were children. This just shows you a little bit about the reimbursement rate for Kentucky Medicaid. This study was done by the American Dental Association, and in aggregate, Kentucky reimburses our dental providers at 104.8% of the average commercial rate. We have, again, looked at various studies related to dental care, and there is a study that shows that public benefit programs for adults are financing downstream by paying for invasive treatment of dental disease for adults rather than preventive treatment that may avert such disease in the first place. And that's one other thing that we want to do. We definitely want to start focusing on prevention rather than having individuals go to the emergency room for treatment for, as we said, these invasive dental treatments. Currently, since January 1st of 2023, this is showing Humana. We have 6 managed care organizations. Humana has covered a total of 616 services for a total of $92,864. Humana for Vision has covered 32,776 services for $119,360. Molina has covered 962 services, totaling $299,531. And Aetna has, for their dental services, you can see they have covered 715 unique members for a total of $237,821. And you can see the other vision and hearing benefits that they have covered. United has covered 32 claims for 60 members for dental. They've done 2 hearing claims and 166 claims for members. We also have WellCare. I didn't get their information in here, but that WellCare has covered 3,542 services totaling over $456,000. And Anthem has covered 147 services for members for a total of 147 hearing, 1,107 individuals for vision, and 86 for dental. So all total, our providers in Medicaid have received over $1.5 million in reimbursement for these expanded services in vision, dental, and hearing. One provider, I've noticed in Clay County, for example, one provider since January 1st has delivered 4 sets of dentures to members, and he has 44 more in progress for members in Clay County alone. And as you can see in this map, the highlighted areas, the orange shows that at least 61 to 80% of individuals in that county are enrolled in Medicaid. So source of funding and anticipated future costs. Funding is through current appropriations. We have saved money through reduced expenditures resulting from implementation of Senate Bill 50 when we moved to a single pharmacy benefit manager. Those drug rebates are not revenues, but they do reduce our expenditures, which allows us to cover these services in our current appropriations. The cost of covering these services is about $36.8 million going forward, with the bulk of that, $31 million being federal funds and $5.6 million being state. We do expect the services to ramp up over time, and we'll continue to monitor utilization. So as far as sustainability, we do believe that there are going to be fewer ER visits related to dental pain. Again, the previous slide showed approximately $9 million per year. Studies have linked dental services to reduce costs for diabetes, congestive heart failure, asthma, COPD, coronary artery disease, chronic kidney or renal disease, and these are all things that are impacting a large scale and killing Kentuckians. Unrelated oral health conditions lead to other diseases and even death. The one thing that we're excited about is the ability to identify oral cancers earlier on and get treatment for those individuals. And thanks to House Bill 525, we know that that improving the health status is not simply just providing services. It's also education. And beginning in July 1st of 2023, dentists will be able to employ and bill for community health workers that will allow them to provide, thank you very much, Representative Moser, for sponsoring that bill. We're very excited about it. But the community health workers will be able to provide outreach and education to individuals, and the dentist being able to bill for them will cut down on their no-show visits, which we hear complaints about. And we believe this can be covered without any additional state fund appropriations. And I have a link in here to an article that I read that I thought was very timely. Just earlier last week, an article was on MSN.com, and I think this female was also focused on the Today Show. She was 37. She had no teeth whatsoever, and these are just some comments from that article. Her worsening oral health affected all aspects of her life, her mental health, relationships, job prospects, and overall well-being. Small problems like cavities became a big problem that required visits to the emergency room. Again, if she had had access to oral health care and dental care for her cleanings, this probably would not have been a big issue for her. She worked in service industry jobs such as bartending and that did not offer dental insurance, and she could not afford to get regular checkups for fillings or cavities. And she says she was miserable, and add that to the mental health toll that it takes on you when you're afraid to smile. So that's one thing that we want to do with these expanded benefits is we want to give individuals their smile back. We want them to be able to go out and get in the workforce and be comfortable in job interviews. We want them to be able to hear questions and respond appropriately. And so, again, there's a lot of stigma that comes with having bad teeth, and if we can help those individuals in the Medicaid program, this is the right thing to do. We want to give those smiles back. We want to have individuals enter the workforce. And again, this is just one answer to increasing workforce participation. We have, yesterday, for example, we had a meeting with several representatives from Kentucky Youth Advocates, the Kentucky Oral Health Coalition, both teaching hospitals from the universities, UK and U of L dental schools. All of them are very supportive of the services that we are delivering now, and several providers were on the call. The Kentucky Primary Care Association. The support that came from those 47 individuals on that call was very heartwarming, and we can't wait to continue to give the smiles back to many Kentuckians. I'll be happy to answer any questions. Thank you.
Thank you, Commissioner. Are there any questions from the members? Let's go left to right. Representative Moser.
Thank you, Mr. Chair, and thank you, Commissioner. It's always good to hear your updates. I'm very pleased, of course, about House Bill 525 and getting community health workers embedded in some of these critical areas, and really start addressing the social determinants of access to care, why folks don't access. But my question is, and I would like to work on this with you because I understand the importance of dental care, I guess I'm concerned that this recent expansion is a one-time expenditure, or so it seems. Is there a plan for sustaining the cost incurred, or the second part of my question is about increasing reimbursement rates for dentist, and it looks like we need to really do some rebasing for many areas, BHSOs and so forth. So, on the sustainability plan, are you required to apply for a waiver of some sort?
We did complete a state plan amendment pending CMS approval. So that is our sustainability plan, continue to monitor the services as we go forward. As far as rates, we did increase. We heard a lot of feedback particularly from oral surgeons. So as part of our moving forward, we have increased some specific rates for oral surgeons and general dentists. What we're trying to do is identify those services, target preventative services where we're going to have more impact, rather than giving an across-the-board raise. And we have very active conversations with their Dental Technical Advisory Committee right now on how we continue to improve the oral health care of Kentuckians as we go forward. So very involved with the Dental Technical Advisory Council.
Very good. All right. Thank you for that. I'm all in favor of prevention and less invasive treatment if we can do that first. Certainly it makes more sense for individuals. So thank you.
Representative Wilner.
Thank you, Mr. Chairman. Thank you, Commissioner Lee. Great presentation. And when I saw this on the agenda, I was just thinking about, I think there can be a tendency to think of vision and dental and hearing as somehow separate from healthcare. And you've done such a compelling job now and previously about explaining how it's all connected. And I just wonder if you guys have thought about putting together like a one-pager or any kind of just sort of public awareness plan about how, really profoundly impacting these issues are. So just a thought to help raise awareness and support for what you're doing with this.
Absolutely. I think education is definitely key. And we have our first annual Medicaid 2020 annual report was recently released, and we hope to add to that as we go through different iterations of that report and add some of the information specifically that you're talking about and how we have impacted the workforce, individuals who are moving out into the workforce as we go forward. So absolutely. And we're also working with Kentucky Primary Care Association to develop some informational materials for our members.
Any other questions? Representative Raymond? Representative Bentley? Okay. I have a question. It just went through my mind. When you were talking about implants, where would you an okay for an implant?
Well, again, that would be a decision between the provider and a member. And I can give you, for example, my personal experience. When I was younger, of course, I was raised in Eastern Kentucky. We were very poor. I was faced with the decision to either have a root canal or pull a tooth. Could not afford a root canal. So pulled a tooth. Years later, I go to a dentist. He does an x-ray of my mouth, and he shows me that my teeth at top are shifting. They're falling down because I didn't have a tooth where I'd had it pulled. My teeth were all shifting. And so he told me that if I didn't have at the time a 4-tooth bridge, that I would have to, I would lose most of my teeth. So faced with that, I could not afford that 4-tooth bridge. I didn't know what I was going to do. I ended up somehow finding out about the University of Kentucky School of Dentistry. I went there, had a 4-tooth bridge. It took forever to have. The only difference between that and the dentist that I had seen before was the University of Kentucky allowed me to pay payments. And so that's how I had my 4-tooth bridge. So in today's world, there's an implant, and if somebody has a tooth pulled and they're experiencing those same issues, an implant would be cheaper than a 4-tooth bridge. So those are the sorts of and there could be, various medical conditions. For some reason, somebody could not wear a partial or something like that. But again, it would have to be medically necessary, and we would look at all of those cases. And it's, again, we're not paying for full mouth implants.
When I was at UK, I took several classes at the dental school, pathology and physiology. And they taught us that no one should lose a tooth anymore. And that was Jurassic Park days. So in 1975, they were saying that, you know, you should never lose a tooth. Pops out, stick it back in. We saw that at UK basketball game many years ago. But implants are interesting things. They run about up home about $3,500, you know. And I'm like you. I'm from Eastern Kentucky, where my family believed in pulling all their teeth and getting dentures, and that scared me to death when I was younger. So I put a lot of money in my mouth, enough to buy a new car. Let's put it that way. Other thing is, on SB 50, we should be thankful for that bill. It gave you a lot of extra money to do these good things for people. But like Representative Moser, we're concerned about that money. So, okay. So, any other questions from the members? Okay. So, thank you, Commissioner Lee, for being here. Before we adjourn, members, please note that we will meet next week, March 1st, for our final meeting. And then Dr. Fordham will get a hold of all of us for our visit to the lab. Okay? Or I will. I don't want to put it all on our shoulders. So the next item is adjournment. Do I have a motion?